The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerreview.com/WNX860. Downloadable practice aids are also available.
Hello, this is Dr. Joseph Corey from the MD Anderson Cancer Center in Houston. Welcome to Visualizing Progress for TP53-Mutant AML, a pathology-guided journey from biomarker principles to modern treatment. You may notice a prominently displayed microscope, one of the tools of the pathology trade. During this activity, I will invite you to join me as we go through the lens together and explore a very important and challenging aspect of AML care: the identification of P53 mutations, the assessment of their prognostic, as well as their clinical relevance. Let's begin by asking a few simple questions. What are P53 mutations, and why are they relevant to AML? To find answers, we'll have to explore the biology and prognostic impact of this molecule in cancer cells. So let's go look through the microscope and see what we can find there. We've known for many years that P53 regulates hematopoietic stem cell functions under both physiologic as well as pathologic conditions. You can see in normal hematopoietic stem cells, P53 acting as a regulator to sense stress and direct the cells to differentiate and to survive in a manner that avoids acquisition of mutations and acquisition of other genetic alterations that might lead to cancer. But despite those checks, P53 mutations do occur and do take, and they lead to various types of myeloid problems, including bone marrow failure, including aberrations that lead to clonal hematopoiesis, as well as abnormalities in conjunction with other mutations and cytogenetic alterations that lead to flat-out myelodysplastic syndrome and acute myeloid leukemia. So P53 functions as a critical node within a complex cellular network where P53 acts as a gatekeeper. The P53 function is actually tightly regulated because this molecule plays such an important role. It is a regulatory process that has been conserved across evolution, where P53 detects cellular stress that results from DNA damage, from activation of other oncogenes, oxidative stress, or glucose deprivation. And it directs the cells through various fates, including DNA repair, apoptosis or programmed cell death, as well as other processes such as autophagy and cell cycle arrest. P53 mutations have been detected in various cohorts of AML using next-generation sequencing and other techniques. In the Cancer Genome Atlas, or the TCGA dataset, 8% of AML patients had P53 mutations. This is in adult patients with de novo AML. When we look at other subtypes of AML, for example, therapy-related AML, which is AML that arises in patients who had been previously exposed to chemotherapy or radiation therapy, the rate, the incidence of P53 mutations is actually much higher and reaches 27%. In certain data sets. And as you can see here, and again, this has been replicated in many studies, P53 mutant AML patients have a much worse overall survival compared to patients overall with P53, with wild-type P53. So now that we know something about P53 mutations in AML, let's turn to the obvious and very practical next step. How do we detect these mutations? How do we capture them? And the answer is with nearly every tool available to pathologists. Let's again look through the microscope and find out more. P53 mutations can happen at various stages in the development of myeloid neoplasms, which in turn are quite heterogeneous diseases. And when we think of AML, we think of AML as arising from hematopoietic stem cells that might have received a genetic hit, including a hit with P53. Or we could think of AML along other dimensions, such as AML arising following myelodysplastic syndromes, which we call acute myeloid leukemia with myelodysplasia-related changes, or AML that might follow myeloproliferative neoplasms. These different types of AMLs from a clinical standpoint are also associated with different genomic characteristics when we look at P53 mutations per se. So as our tools have evolved, we've moved from identifying acute myeloid leukemia at a cellular level. We've progressed to understanding better the cytogenetic makeup of acute myeloid leukemia through identifying the copy number status and rearrangement status of particular genes using fluorescence in situ hybridization. And for the past decade or so, we've been able to probe even deeper and study AML at the single nucleotide level and even beyond by understanding epigenetic regulation in this disease. At our institution, next-generation sequencing is performed on every patient who presents with a myeloid neoplasm, including acute myeloid leukemia. We have an 81 gene panel that we evaluate carefully on every patient. We obtain data at baseline, and we also obtain data at follow-up. Now, it's important to remember that next-generation sequencing entails an interpretive component that highly trained molecular diagnostic pathologists are capable of performing and do perform on a regular basis. And so when we think of next-generation sequencing, it's important to recognize that not every variation is a mutation. Some mutations are understood clearly to be somatic mutations that are pathogenic, but other variants could be of possible germline origin, whereas others are known to be polymorphisms or variants that are present in individuals who are otherwise healthy. Usually making those distinctions is easy, but sometimes that takes an educated call on the part of the molecular pathologist. Another aspect to remember about next-generation sequencing is that we're not only typically saying whether a mutation is there or not, we can also determine what we call the variant allelic frequency, or VAF, which is a mathematical estimate that indicates how many cells in that sample seem to carry a particular mutation, for example, P53. So think about P53 mutations along those lines, i.e. in terms of their pathogenic potential, as well as their abundance in a particular sample. We can also determine whether the P53 gene as a whole might be deleted or sometimes amplified. But what's important for P53 is copy number loss of the P53 gene. One of those tools is array-CGH, or array comparative genomic hybridization. And as you can see here, array-CGH can give us information that indicates whether the P53 locus at 17p13 is lost in a particular sample. Similar data could be obtained by using FISH, which uses fluorescent probes that you can see an example of here, where the P53 locus is highlighted with a red pseudo color, and in the section designated as abnormal, you see one red color indicating that the other P53 allele has been lost. Whereas on the far end, you can see intact signals for both P53 in red, as well as the centromeric region of chromosome 17 with a green pseudocolor. Yet another way of determining P53 abnormalities is using immunohistochemistry. P53 mutations are very commonly associated with overaccumulation of the P53 protein in the nucleus of neoplastic cells. The reasons for this are many and complex, and we will not cover them here. Suffice it to say that immunohistochemistry, as a result, provides a very powerful tool for us to recognize the presence of P53 mutations, as well as often copy number losses in tissue samples from patients who might have P53 mutations. You can see here an example of a bone marrow biopsy from a patient with therapy-related AML. You can see also an immunohistochemistry stain showing P53 overexpression, or rather, although we use the term overexpression, it is rather accumulation, indicated with a brown signal here. This patient had a complex karyotype and also, as you might imagine then, harbored a P53 mutation, V157L. So what do we do when we have a patient with AML on whom we have a bone marrow sample, a set of samples rather, that might give us information about the subtype of AML, as well as about potentially the status of P53? To do that, ideally we want to correlate morphology with flow cytometry, cytogenetics, and molecular studies. And in particular for P53, we want to consider obtaining P53 mutation data on patients who have therapy-related AML or AML with myelodysplasia-related changes. This subset of patients with AML is commonly enriched for P53 mutations, and for reasons we will cover shortly, identifying P53 mutations in these patients is now of therapeutic value. These are the broad categories of acute myeloid leukemia and related neoplasms. And as we mentioned, AML with myelodysplasia-related changes, as well as therapy-related myeloid neoplasms, commonly harbor P53 mutations and thus should be frequently evaluated, or should be always evaluated, for P53 alterations. At this point, we have our tools in place. We know something about P53 mutant AML, and we understand how to interpret and promptly report testing results. Unfortunately, this is where the challenges mount, because as we've touched on before, up to the present day, our current therapeutic arsenal has been very limited in our ability to treat P53 mutant AML. However, there are some really exciting new developments in this classically high-risk disease setting. Once more, we're going to look through the microscope and see what we can find. We've known for a long time that P53 mutations, as we indicated earlier, are associated with poor outcomes in AML. Those poor outcomes actually carry forward despite allogeneic hematopoietic stem cell transplantation. This is a study that shows that P53 mutated AML patients do quite worse than patients with wild-type P53 despite allogeneic transplantation. This adverse impact is also present when patients are treated with venetoclax-based regimens, both with cytarabine and with hypomethylating agents. This has been shown by multiple groups. Two ASH abstracts have described this in detail. In a recent publication by DiNardo and colleagues have showed similar findings, with P53 mutant AML being resistant to venetoclax-based regimens, which are becoming slowly a standard of care for AML patients. Another avenue for treating AML is by blocking CD47. Under normal conditions, normal cells and cancer cells evade macrophage phagocytosis by expressing CD47. In cancer cells, CD47 is commonly overexpressed to protect the cancerous cells against the expression of eat me phagocytic signals and thus evading immune surveillance. So using CD47 blockade, this protective mechanism is removed on cancer cells, allowing macrophage to eat them and promote an immune reaction against them. Magrolimab, which is an anti-CD47 agent, and azacitidine has been shown to be effective in untreated AML patients who are ineligible for induction chemotherapy, as well as in untreated MDS patients with intermediate to very high-risk disease. In P53, Magro plus AZA have shown promising results, including 69% overall response rate and 42% clinical remission. These encouraging results are seen both in patients, in AML patients with wild-type P53, as well as patients with mutant P53, and this provides a new promising avenue for such patients. You can see here that Magro combinations are also effective against P53 mutant myelodysplastic syndrome, as you can see in this figure. Another avenue that is becoming available for AML patients with mutant P53 is using novel molecules that can restore the function of wild-type P53 in P53 mutant AML cells. This can be done using agents like APR-246, which is a first-in-class small molecule that's been tested in clinical trials. In a recent study published by Clouzot and colleagues out of France, 52 P53 mutant patients, which included 18 AML patients, were treated, and AML patients had an overall response rate of 33% with 17% clinical remission. In these AML patients, those who had less than 30% blasts did much better, but still, this is providing a very encouraging avenue for treating AML patients with mutant P53. It's important to note that in this study, 73% of patients who responded actually showed evidence of reduction in the mutant P53 VAF, reaching less than 5% when they evaluated these patients by next-generation sequencing. In another study by Solman and Komrokji, published in JCO this year, a similar finding was reported using APR-246 and azacitidine in P53 mutant MDS patients. Along similar lines like those reported by Clouzot, P53 VAF went down in patients who achieved clinical remission, and this was also observed during using immunohistochemistry with P53 IHC positivity similarly going down in a commensurate way in those who responded to APR with azacitidine. So we've now come a full circle from the biology of P53 mutations and their role as a powerful prognostic factor to the tools that we can use to capture and hopefully treat patients with this high-risk AML subtype. I'd like to leave with a few take-home messages that I hope can provide you with guidance for your practice. And one more time, let's go through the microscope together for synthesis of the material we've discussed today. So as we look at patients with AML, it's becoming increasingly important to perform next-generation companion diagnostics and tease out specific subsets of AML patients who might benefit from various types of therapy. It is fair to say that until now, patients with mutant P53 AML have been part of the left behind cohort where very few treatment options existed. But now we have several options that might become useful therapeutic options for patients with P53 mutant AML and MDS. And some of those options we discussed today. So as we move forward, it becomes very important to create practice patterns in collaboration with the treating clinicians to detect P53 mutations at baseline in high-risk subsets of AML, and to have tools in place that would allow following those patients up, especially those who undergo treatment with P53 targeted therapies or therapies that preferentially seem to help patients with P53 mutations, such as magrolimab and APR-246. So the take-home messages are that P53 mutations confer an adverse prognosis in AML. These mutations, though, can be detected using a variety of laboratory tools that includes mutation-level detection tools, as well as locus or P53 gene locus level tools, such as FISH and array-CGH, in addition to immunohistochemistry, which provides a powerful, quick tool for screening for mutations in P53. It's important to remember that P53 mutations are enriched in specific subsets of AML, and that P53 mutation status is evolving into a biomarker of therapy in AML, as well as MDS. Thank you very much for joining us today. This concludes our journey through the microscope to explore the role of pathology in capturing P53 status in AML and informing the care of these high-risk patients. I really hope you found this program interesting and useful for your practice. Thank you very much for joining me. You can reach me anytime at Joe Corey MD on Twitter, or email me at jcorey@mdanderson.org. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/WNX860. This activity is supported by an educational grant from Gilead Sciences. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.